when you're planning pregnancy or on this journey, just remember that everything happens for a reason and everything happens on its own natural time. Let things fall as they may.
Welcome to the Surrogacy Scoop, a podcast brought to you by Patriot Conceptions, where we demystify the world of surrogacy from the clinical, family, and surrogate perspective. I'm your host, CJ, and today I'm sitting down with Dr. Dawn Royster and Egypt Fitts. Dr. Royster is an Air Force Academy grad with an over 20-year career in the Air Force. Before retiring at the rank of colonel, he performed over 5,000 surgeries and delivered over 1,000 babies during global deployments and humanitarian missions. Currently, Dr. Royster is a partner at the Southern California Center for Reproductive Medicine, where he practices as a double board certified physician in reproductive endocrinology and infertility and OBGYN. Also joining us today is Egypt Fitts, an IVF and third-party coordinator at the Southern California Center for Reproductive Medicine. She graduated nursing school in 2017, started as a float pool nurse for 3 years, and after the pandemic, found her way into the world of fertility. Welcome to the show, both of you.
Thank you for having us.
I am so excited to get into our conversation today. I'm really excited to pick both of your brains on this topic, but before we jump in too deep, let's get to know you a little bit. So as far back as you want to go, how did each of you get involved with the surrogacy industry?
Well, I am the prototypical non-traditional kind of physician where I've probably had 3 or 4 careers in my lifetime so far. So when I first left high school, I was the first in my family to go to college and, of course, to eventually become a physician, but went to the Air Force Academy to serve my country and had an engineering degree and served as a bioenvironmental engineer in the military, where I had deployments and had experiences that opened my eyes to operational medicine. And so started off with being a physician and a flight surgeon, going to OBGYN. I had no understanding about fertility care or reproductive surgery. And so saw that for the first time as an intern and was hooked. Did some research, had mentors that were IVF doctors ahead of me, and then eventually found my way to fellowship training at the National Institutes of Health in Washington, D.C. And after finishing, I was the IVF director there at one of our 6 military IVF centers in San Antonio, Texas, before I retired in 2020. And in the middle of COVID, moved to Southern California with my pregnant wife, and we now have a 4-year-old daughter. But it was a very non-traditional way and path to get where I am, from engineering and medicine and now fertility, which is kind of our passion.
I would say for myself, I always knew I wanted to be a nurse, but the type of nursing I wasn't quite sure of just yet. But after the pandemic, I took a little time off and wanted to find happy medicine. I got a little tired of dealing with sick people and meeting them on their worst days and giving bad news to family members. So I started looking for some happy medicine and found my way into fertility. And I was interested in fertility because I myself had been an egg donor before. So I knew just a little bit about it. But once I got into the realm, I absolutely fell in love and love working with patients and teaching them and helping them achieve one of their biggest goals.
Awesome. Well, thank you so much both for sharing. There are so many interesting perspectives that I think you bring to this conversation that I'm really excited about today, especially that being, not that you're new to medicine, but newer to the surrogacy world. Both of you are. And throughout a lot of these conversations I have, this seems like an industry that changes like day to day. We're having, new challenges come up, or, things change very on location all the time. It's really interesting. I think that both of your perspectives will definitely be interesting hearing on that, just because of all the changes we've all experienced since 2020.
Yeah. For me, in the military, as an example, we are not allowed to have surrogates. At many locations, we could only use donor sperm and not even use donor egg. So a lot of the third-party options that we have in the civilian world, we didn't have access to in military medicine due to numerous medical legal limitations of being, in the military or a military member. And so having a practice that I'm with now, where we probably have maybe 25% of our intended parents that are international, that need surrogacy for one reason or another, maybe another 25% that are part of the LGBTQ plus community. And then probably the other 50% that are couples that for one reason or another couldn't, carry a pregnancy to term themselves. And so to be able to see one side of the spectrum where you had limited capabilities and then now have full spectrum capabilities is tremendous. And then obviously over the last few years with changes in laws and kind of the loss of Roe v. Wade protections, even before that happened by the Supreme Court, we had patients that were seeking care with our clinic here from other states that had more limited resources just because of their fear of the disposition of their embryos. So we've seen that coming well before the Supreme Court changed their ruling on that.
But I think that just really encapsulates maybe a lot of the feelings that people have towards surrogacy and why there's a lot more of a spike of it recently, or just interest aside from, it being in pop culture in various ways. It's showing up in the news a lot more and it's affecting a lot more people than it ever has before. So I think that just gives us a good opportunity to explore it and kind of share the knowledge with people who, this can be a good resource for them.
Yeah. It's tough because I think that, as of the day that we're taping, there's legislation in Congress today to protect IVF access for, citizens, across the nation. And so it's tough because you're not going to have universal coverage. You're not going to have universal laws that kind of govern this community and these needs. So the access to care that we have in California is going to be different than in Louisiana or Nebraska. And so because we have more capabilities here on the West Coast, then we obviously have a bigger patient population that seeks care from outside of our area. And then we have surrogates that come from all over the country. And so it's not just limited to gestational carriers from this community, but from throughout the United States.
I would say one thing that on the flip side, that's a positive change that we've noticed is that more employers are now offering some sort of fertility coverage. So now people that either didn't have access to it before or the financial means now have a little bit of help through their employer to be able to get either IVF care for themselves or go the egg donor or sperm donor route, or some women or just families in general need to use a surrogate for medical reasons or just lifestyle reasons. They're not able to successfully carry and maintain a pregnancy. So the introduction of insurance and the more broad spectrum coverage has definitely been helpful. Seen an increase in patients that have some sort of coverage.
I think it's just this week. We last year in California passed a law where we, in essence, mandated that insurance carriers cover fertility care, but it didn't include IVF services. And currently in California, we have legislations passed by both houses that's now on Governor Newsom's desk that, in essence, redefines what infertility means and also includes IVF services with, I believe, up to 3 IVF cycles in the fertility care that needs to be offered by, major healthcare organizations. And so previously it was very dogmatic. You had to have, unprotected intercourse for a year without successfully, having a pregnancy between a man and a woman. It could be as short as 6 months if you're over 35 for those women, unless there is a distinct reason that you can't conceive, chemotherapy, you had your ovaries removed, or some other reason where you didn't have to wait an entire year. And now the definition of infertility has evolved to include any condition where you don't have access to eggs or sperm and or a uterus for one reason or another. And so it includes a lot of conditions that need surrogacy or need egg donations, just with how we nationally defined it by the American Society of Reproductive Medicine, defining infertility. And then with these new laws that are coming hopefully on the books pretty soon, that includes those other more broad definitions of infertility for coverage. And as more people are covered and have access to care, then obviously we can help more couples that previously couldn't be helped because of cost restraints.
Mm-hmm. Yeah. I mean, it just highlights how much is changing, right? You have things being discussed right now as we're shooting this podcast that could change your job tomorrow. So I'm excited to dig into it a little bit today. I think this is a good chance to get started. in conversations previously, we've used the term surrogate and gestational carrier kind of independently or about the same. So if you want to define those for us, and then also maybe let's dig into a little bit, how is a gestational carrier picked, either from the intended parent's perspective or from your perspective as fertility providers?
Yeah. So when you have a gestational carrier, the idea is that that woman that's carrying that pregnancy is not biologically related to the offspring that they're going to hopefully deliver, as opposed to surrogacy. And, they had some traditional surrogacy that is no longer allowed in the United States, where you may have a woman who's both donating her eggs and with the use of someone else's sperm carry a pregnancy that she intends not to keep, but because it's her egg, she is biologically connected to that pregnancy and that delivery. And so nowadays, with just traditional gestational carriers, again, there are two main ways that families find a GC. We'll just say that for short. One is if through their family or friend network. Obviously, there's huge, closed Facebook groups for those kind of needs, because it's a very expensive endeavor. And so if someone has a close family member or a close colleague or friend, or a member in their church, then having that connection can kind of help defray some of those costs. But for most people, they don't have access to someone close enough that can do that for them. And they have to rely on, third-party agencies like Patriot Conceptions to find and recruit adequate surrogates that can then be matched with their intended parents on the back end. And, these days, as opposed to non-identified egg or sperm donation, it's totally open. The families are able to interview these potential surrogates or just gestational carriers and be able to just get a feel for them as a person, because we can go over all the kind of clinical things that you look for in a appropriate GC, but that family has to be comfortable with the person that they're picking, because they're literally carrying their baby, and they have to trust that they're going to provide a safe and secure environment for their pregnancy of when the time comes for them to deliver that precious child. And so that relationship's a lot closer. Those intended parents are able to come and attend any appointment that the GC is involved with. And so, again, it's a cooperative kind of environment that I think is really special.
Absolutely. When parents are picking a G, at least from, I can talk more from the clinical side, once they've found someone that they liked, whether it's someone in their home or not in their home, but someone in their close family group or friend group, or whether it's someone through an agency, once they've picked that person, then either the agency sends over all of the GC's records, or the GC will personally send over all of their records for pregnancies and deliveries and just general health information. We'll review those to ensure that they don't have any chronic medical problems, to ensure that their previous deliveries were uneventful, basically easy peasy deliveries. We're wanting to look for histories. Like, we don't want them to have preeclampsia or hypertension or gestational diabetes. Like, we want them to be just a general, uneventful, healthy pregnancy. We also look at things like weight, as someone that's overweight can pose more complications during the pregnancy and or delivery. So we want them to have a normal BMI. We're also looking at just home factors. We do a mental health screening with a psychologist to ensure that they are mentally and emotionally stable to carry this pregnancy, because even though they're not genetically related to the child that they're carrying, it's still emotional. It's still it's still something big. It's not a small feat that you're taking on, and it's going to be for a long time. So we want to ensure that both clinically, are you okay to carry this child medic wise, and then mentally, are you okay to do this journey and still maintain your regular life? Because a lot of our surrogates, or a requirement for our surrogates, our GCs, is that they have had a child before. So they have a child at home that they're also caring for, which is another added layer of, we have to make sure all of this works for everyone involved.
Hmm. Yeah, there's so many unexpected factors that you would think that goes into being a GC. It's always surprising to hear all the additional things that you check for just besides general physical medical health. So I appreciate you going into detail and sharing all that. If we take a next step into the journey of being a GC, what is that next step? Would that be screening?
Yeah, so after their medical records are sent to our team and our nurses are able to review their records, they have to, in essence, make it past two, filters. One is the agency filter themselves and any health professionals that they have reviewing their health history, their questionnaires, their medical, records, and then on the fertility clinic side. And so then there's that second screening where we say, okay, they meet criteria until they're actually brought in for an in-person evaluation. Even if we have surrogates or GCs that live in other states, we prefer them to fly here to Newport Beach, California, to have that in-person examination. It includes FDA-required blood tests. It will also include a head-to-toe examination, transvaginal ultrasonography. And in our clinic, we add an additional step, maybe two steps. For all surrogates, they're going to need an office hysteroscopy. It's, in essence, a camera test of the cavity of the uterus. Usually takes only about a minute or two. It uses saline and a camera with a fiber optic light to look inside the uterine cavity to ensure that you don't have any like inflammation inside the uterus or scar tissue or polyps or anything else that might prevent implantation. Again, we have the capability of doing that in the office just with oral pain medicines, very well tolerated. And it's considered the gold standard for evaluating the uterine cavity, because some clinics use a saline ultrasound where it's ultrasonography just with saline, but a lot of the details of inflammation and other, small scar tissue may not be visible on ultrasound, which you can actually see with a camera. And so all of these surrogates are getting that head-to-toe exam, that ultrasound, and that hysteroscopy here at our clinical location. And then if it's a first-time surrogate, meaning they've only had children for themselves and they haven't had a successful embryo transfer in the past, for those surrogates, we do recommend that they do a mock embryo transfer cycle, which for us includes the endometrial cycle. It's the endometrial receptivity analysis, where in essence, we give them the same protocol of medicines that we expect them to use prior to an embryo transfer. And at the end of 3 weeks, instead of a transfer of an embryo, we do a biopsy from the inside lining of the uterus. That way we can see on that particular day, was the uterus ready for the embryo? Or did they have to modify their protocol in order to see if their uterus is ready? And at the same time, we can evaluate 31 different bacteria to see is there a balance of good and bad bacteria. Because if not, we would recommend antibiotics or vaginal probiotics prior to the transfer. So if they're a first-time GC and they've never had a transfer or they've had an unsuccessful transfer in the past, we'd recommend doing that receptivity test first. And it's typically 1 month before the real thing. So that added step is something that's, not proprietary to our clinic, but it is a little more conservative. And I'll talk here in a minute about, why we came to that decision as a clinic a few years ago to recommend that to intended parents for first-time surrogates.
I'll say that testing is definitely good to help ensure that we are transferring at the most optimal time, because when we're dealing with intended parents that are using a gestational carrier, they are investing not only emotionally but also financially. So we want to ensure that we're transferring the embryo at the right time, at the best environment, that this person is physically healthy and can maintain. Just because when we are working with just the human body in general, we can't, not everything is the same. Just because this person's been pregnant on their own, successful, no issues, doesn't mean that the standard protocol that we use for our embryo transfers will necessarily match what their body needs. So we want to make sure that we're personalizing, their treatment to them so that they're getting the best chances out of each cycle that they go through.
Yeah, and something I picked up from what both of you said, especially there a little bit at the end, Egypt, is just the really personalized and very highly attention to detail minded answers that you're both giving, and the way that you're talking about this process really seems like the your practice is very focused on that individual success and trying to just offer the highest quality of care. Maybe could you both talk to a little bit how that kind of mindset or maybe value came to be at your office?
Yeah, I guess it starts at the top. My senior partner, Dr. Anderson, and I have been doing this a long time. And literally, each embryo that we use, we treat it as if it's our own child. Some families have 10 euploid embryos, genetically normal embryos. Some families have one. And so each one is precious. And we want to give each one that highest chance of success. Thankfully, over the last decade, we probably are maybe top 10 in the United States for pregnancy rates. And when we're
Wow.
looking at surrogates that are, best case scenario, young, healthy women who've had children in the past, their pregnancy rates are even higher than our typical pregnancy rate. So each genetically normal embryo has about a 75% implantation rate. And for those GCs who are a first time surrogate, who is having their very first embryo transfer, they have a slightly higher chance of success, probably about 82%. And what we found maybe 10 years ago is that a lot of the patients, maybe 50% of our patients, are patients who were unsuccessful at other practices or were unable to carry their own pregnancy, even with a high quality, good quality, genetically normal embryo. And so for them as a family, they did that receptivity test, that ERA test, to identify the best timing. And then again, even with that testing, they still were unsuccessful with themselves. And so when they finally sought a surrogacy agency, they, in some instances, requested that we do that same test of that first time surrogate that we did for her prior to her most recent transfer. And over a 5-year period, we noted that we had a handful of patients who were able to do a retrospective study where we looked at 80 first-time gestational carriers. The 4 of them that just did the traditional protocol without any additional testing prior to their first transfer, and then 26 other GCs that had that receptivity test. And for those patients that had the ERA test and we were able to personalize their transfer, they went from about 81 to 82% implantation rate up to 92% over that time period. It was statistically significant and enough that we started recommending that to intended parents to say, hey, the literature is mixed when it comes to ERA. For good prognosis patients, it's probably not a test that everybody needs. And in some clinics, when they did studies, it's not always of euploid embryos. It's not always during a frozen embryo transfer. It's hard to generalize ERA data from other clinics and other studies in the past. When we studied it with our laboratory and our embryos and our patients, we saw at least a 10 to 15% higher implantation rate and associated live birth rates for our best prognosis patients, which is that first time surrogate. And so everything that we do in this environment is elective. And so that's our recommendation. If it's a GC that's never had an embryo transfer, we see it probably 50 to 75% of the time, where either they're not receptive when we thought they should be, or there was a bacteria that needed to be treated. And when we do that and we see the success, then we continue that.
I was going to say, just touching on the personalized aspect of care and, coming from the top down, both of our doctors here are amazing, both very personable. Both doctors call all of their patients after each appointment to go over dosing, to answer questions for them. And then all of our nursing staff here, we're very hands-on. We all work together. We're all well-versed in both fertility realms, our doctors' protocols and procedures, and just what comes next and how we need to treat and manage each patient. And so they've done very well at screening us and making sure they've got good people on their team.
Got a great team.
And we definitely support them in our best way possible to make them look good and shine and make us one cohesive and happy place.
Mm-hmm. Thank you both for sharing that. And, that reminded me of another through line I hear a lot in these conversations is the people and the team and how much that matters, how much the people that you're working with, even, from everyone's perspective, from the intended parents, from the GC themselves, how much that relationship matters and how much trust there is in the medical team. So it's interesting that you bring that up again.
Yeah, we have staff and nurses that have been with us 25 plus years, administrative staff with us over 20 years. And so it's definitely a family. It's not a revolving door where, We have nurses or physicians. I'm the first partner of Dr. Anderson in being in practice for 35 plus years. And so we're a small, basically family owned practice. And so we're able to provide that quality care and that touch where it's not just you see your doctor at your first visit and then you don't see him for months later until there's a surgery. And then you see my staff, the nurses along the way. No, you're going to see your doctor all along that way and have access to us on a daily basis.
I would say for people that are new to fertility and don't quite understand, you see us a lot through your fertility cycle. When you're doing IVF, you're seeing us here in our office, you're seeing us every other day. So you really get to know the nurses, you get to know the doctors, and you develop a relationship. And it's relationships that we all cherish, because when they get to the graduation point of graduating because they're pregnant, now they're going off to their OB, it's always hugs and smiles. And it's so bittersweet because I want to come see you guys again, but I know I need to graduate because this is the good part. And it's so special for us because we're so happy. Every time there's pregnancy tests, all the nurses are like, fingers crossed. I tell the lab guy, only bring us back good news, because we are all invested. We want to see our patients pregnant and fulfilling their family goals.
Wow, incredible. Just like makes my heart sink hearing you share the stories just from your office and from your jobs. I find that so rewarding. And something else I'm a little curious about is you both have, as we touched on a little bit at the beginning of the podcast, backgrounds that are not traditionally related to fertility. So if you mind both sharing a little bit of how you feel your past lives or maybe past experiences influence your roles today.
Oh, wow. I guess two big stories stand out for me. One was my first deployment to El Salvador, and I was with a medic. Before I was in clinical medicine, I was an engineer, and my medic got dengue fever, and I had to start my first IV in the middle of, third world country. And just seeing how special it was to have that personal connection with just clinical care when you're vulnerable was just like, wow, this is where I want to be. And that's what cemented my decision to, change course in my 20s and say, I think I want to be a doctor now. And then, fast forward a few years going through clinical medicine, we know that maybe we don't all know this, but 50% of all pregnancies in the US are unplanned. And obviously some people choose to not continue with that pregnancy. But for those families that do continue with that pregnancy, whether they are educated, high school educated, master's degree, whatever it is, they're all in typically. And in the military community, for most of the patients I took care of while I was still in the military, they have access to care. So you didn't have to worry about them being able to afford their medicines or their vitamins, being able to, afford prenatal care and coming in for, their deliveries. And like Egypt said at the beginning, it's good to be part of something that's happy, because most people that are at the hospital or clinic are there because they're sick or hurt, and they don't want to be there. Mm-hmm. But even if that pregnancy was unplanned and they're at term and they're in labor, they're all in at that time. So being able to share in that is just wonderful. And then for us to be able to share in that journey, I'm one of the few fertility doctors that routinely, and Egypt can attest to the Christmas story, but routinely I'll be able to help families, get ready for pregnancy, either with surgery or minimally invasive surgery, testing, fertility care, transfer of an embryo. We follow them the whole first trimester, and 99.99% of my colleagues then graduate them to someone else who's going to deliver. And in my practice, maybe once a quarter, once a month, I would continue to follow certain families all the way until term. And I would come in on my day off to deliver them. And, I have a baby wall full of families like that, where they just weren't families that I helped conceive, but I actually came in and delivered them because I was still a practicing OBGYN, even though I was doing fertility care. And so this past Christmas, we had a special story where we had twins that we helped bring into this world. And she was in labor on Christmas morning, just a couple months ago. And her OB wasn't on call, and the backup OB was on her way. And she called, it's like, I want Dr. Royster there. And I was already planning to do her a planned C-section, which was after Christmas on a particular Friday, but babies came early. And so she was uncomfortable because she didn't know any of the physicians at the hospital and wanted a familiar face. And so here I am 6 months later coming in and, helping with her C-section on Christmas morning of her twins. And, now they're about 9, 10 months old and doing well. But having that kind of, relationship and that kind of connection is just, it makes it worthwhile because what we do is hard and it doesn't work for everybody. And I wish it could, but being able to share in those kind of experiences, makes it worthwhile because we do everything we can for all our patients to hopefully get to that family building goal of theirs, whether it's their first child or their next child. It's just as important.
I would say for myself, I guess you could say my pathway is a little not as linear as well. I always knew I wanted to do nursing, but when I first attempted to get into nursing school, like most nursing schools still are, it's very hard to get into. They're impacted and it's a lottery. So I didn't get picked on that lottery, and I ended up studying gerontology, which is the study of the elderly. And I
Opposite end of the spectrum.
totally opposite end of the spectrum. So I found that I love the really old and the really, really young. Working with the elderly definitely taught me a lot of patience, a lot of listening, a lot of understanding. And I feel like being a caregiver and working with them definitely helped me in my career as a nurse and allows me to be empathetic, allows me to be more patient, allows me to explain things in 6 different ways because sometimes your clearest way of explaining something is as clear as mud to someone else. So I feel like working in that field and taking care of the elderly and even the sick and dying at that point, it really helped me be able to be empathetic and do what I do now. Because even though I do work in happy medicine, not every story, as Dr. Royster was saying, ends in success. Sometimes we are calling with, a negative test, or we're walking into the ultrasound, things are great, we're doing the ultrasound and things are not great. So I feel like that background has helped me be able to maintain composure and then also help them through whatever feelings they're going through. Because when you walk in pregnant and you're walking out crying, it's really hard.
That's tough.
It's really, really hard. So you gotta have a good team around you to help support you and get you through that.
Mm-hmm. Very interesting perspectives you both shared. I could ask you a million questions about your background, Egypt, from literally completely opposite ends of medicine. That sounds so fascinating. And as you said, I think gives you a really unique skill set. Do you have maybe any examples of stories you'd like to share of a time where you really felt like that shone through, or that, your prior education helped your role now?
I don't know if I have one that stands out to me in particular. I know just dealing with patients over the phone, sometimes I tend to get the patients that need a little more hand holding. So when they come through, they're like, Egypt, you take her. Egypt, you take this one. So I've definitely worked more with patients that need a little more hand holding. I've actually worked a lot with our international patients that don't speak English. I
Oh,
tend to
wow.
be the one that gets those patients, and those are really rewarding situations just because we both don't speak the native language. We're trying to communicate using a device or a phone. But when we get through to one another, it's very special because they're very, very appreciative of the time that we've taken to educate them, to answer all of their questions, to walk them through from beginning to end. I have a few patients who, after they delivered, they emailed me the pictures and they're like, my baby's here. I wanted to tell you. I'm so excited. Please share it with the doctors. I'm like, oh my gosh, I feel so special.
That's so sweet. What a role. I feel like, Dr. Royster, you must be pretty thankful to have somebody so
Oh
resilient
yeah,
with
definitely.
communication.
That's why she's here by my side now.
Well, awesome. I really feel like we've covered a lot of interesting perspectives today. Again, both your time is worth $1 million a minute, so I'm not going to hold you on the podcast all day. We'll definitely have to do a follow-up though, because there's a couple of rabbit holes I would like to go down. But as we kind of wrap up here today, is there anything, maybe a word of advice or just things on your mind currently related to the surrogacy industry, that you'd like to share with our audience today?
Yeah, I guess my closing thoughts would be, one of my mentors always said that for families coming through this fertility journey, sometimes they don't understand that it's a marathon. And they didn't know that they were lacing shoes up for a marathon. They thought they were already towards the finish line, just coming in the door. And we have to inform them, you're just in training right now. We haven't even gotten to the starting line. And the idea is that for all families, we can help them on that journey. It may not be what they envisioned when they first started that journey, because for most families, they can achieve their goals, whether it's adoption for some families, embryo adoption for others, egg or sperm donation, or use of surrogacy. There are other ways other than what they envisioned, just the traditional, hey, we couldn't get pregnant, so we're just trying to have a little bit extra help. Sometimes they think they just took Clomid, then that would have been the trick. For some people, that's all they need. But for a lot of people, they need a lot more than that. So some people, it's hard to come to grips with even needing to use IVF technology for themselves, and even a harder hurdle when you're involving a third party. And so it's something that you're not going to see commercials during the Super Bowl about fertility or third party care. You're not going to have a lot of family and friends that are going to talk about that. So most people have no experience with it until they're seeing our clinic or other clinics that first mention that, until they have to come to grips. So it's usually many months or many years down that road until they come to that conclusion that that's what they need in order to build their family. And so a lot of times they go into it reluctantly. And, that's the hard thing for a lot of people to understand, is that for some people that might be the only option. It's not usually the first option. There are reasons that we know up front. If there's no sperm, no egg, no uterus, then yeah, we know that we're going to need some help along the way. But for a lot of couples, they don't know that when they start. So it's just coming to that realization and just understanding you're still mom, you're still dad, you're still the parents, regardless of how we get there.
I would say to touch on that, my one thing would be that when you're planning pregnancy or on this journey, just remember that everything happens for a reason and everything happens on its own natural time.
Yeah.
Just try not to rush it. Just let things fall as they may. And then also another thing is to not get down on themselves if they require some sort of third party assistance. I know you get wrapped up in the idea of like, this is how we're going to do this. But when that doesn't happen, I notice a lot of times parents can get down on themselves, like, oh, what's wrong with me? What's wrong with us? Why can't we do this? And I just like to tell people, it is what it is. I wanted to be 6 feet tall and I'm not. It doesn't mean that there's anything wrong. I'm just not as tall. It's the same with the parents. You wanted to go this route to do this one thing, but you had to take a detour. But the finish line is the end goal is still there. It's still the same. You can still achieve it. It's just a different route.
Awesome. Well, thank you so much for sharing that perspective as well. Where can you direct people to if anyone in the audience wants to learn more about the Southern California Center for Reproductive Medicine? Where can they find you?
Yeah, thank you for that. You can go to our website, www.socalfertility.com, or you can call for an appointment at 949-642-8727, located in Newport Beach, California, and just a short phone call or website away from you contacting us.
Awesome. Well, thank you both so much for your time today, and thank you so much for listening. Like I said earlier, can't wait to get you both on for a round 2 episode. But until then, thank you so much for your time today.
Sounds good. Nice to meet you, CJ.
Thank you for listening to this episode of the Surrogacy Scoop, and I hope you found value in this meaningful conversation. For all resources mentioned in the episode, or to connect with Patriot Conceptions online, visit the description. Don't forget to subscribe on your favorite podcast hosting platform, and share this episode with those in your life who may be interested in getting involved.